Good afternoon, respected seniors, colleagues, and dear postgraduates. As you are aware, we are organizing these PG clinics on behalf of IIDVL Andhra Pradesh. With the success and positive feedback of the first PG clinic, which was conducted by Andhra Medical College with around 330 plus registrations, we are even more happy to conduct these consecutive programs. Our second PG clinic organized today is volunteered by Dr. T.S. Mohan Rao sir, Professor and HOD, Department of TVL, Guttur Medical College. Thank you, sir. Sir is our internal examiner for today, and we have a very distinguished and experienced personality as our external examiner, Dr. A. Gnaneshwar Rao sir, Professor and HOD, Department of DVL, SVS Medical College, Mahbub Nagar, Telangana. Thank you, sir, for accepting our request.
Thank you.
Our presenters today are Dr. C.H. Sai Jyotirmayi and Dr. B. Ramya, postgraduates, Guntur Medical College. Now, I request our President, Dr. A. Kavita, to address this meeting.
Good afternoon. A warm welcome to the second session of the PG Clinic webinar series. We are very grateful to Dr. Anguri Gnaneshwar Rao sir, for in spite of his very busy schedule, being the Dermacon organizer, sir as the chairperson of Dermacon, he has accepted to be the external examiner for today. Thank you, sir, for being here today with us. And I extend our sincere thanks to Dr. T.S. Mohan Rao sir for stepping up to lead this session. And this is our 12-month journey where we are aiming to empower our postgraduate students and transform them into a confident postgraduate, so that by the time of the exam they can learn all these cases perfectly. And I thank you all for making the last program success and wishing you a great learning. Thank you.
Thank you, madam. Now I request Dr. Mohan Rao sir to address the meeting.
Respected Professor Dr. Setaram Garu, Dr. Gnaneshwar Garu, IIDVL President Dr. Kavita, Secretary Dr. Saujanya, our faculty members. Good afternoon. Indeed, it is a great privilege and we are honored to conduct this today's PG clinics. And I wish and we hope the PG clinics will be beneficial to the young budding dermatologist. Thank you. Over to Soumya.
Sir, now I request Dr. Gnaneshwar sir to say a few words.
Good afternoon to all of you, and I am really honored to be the external examiner for the PG clinics. No, I thank Dr. Kavita, Dr. Sitaram, Dr. Mohan Rao Garu, then everyone who is involved in organizing this meeting. This is really a good training program for all the postgraduates who are being trained by all of you. And at this juncture, I would like to take you back to the origin of the PG clinics. When I was in Usmania at that time, Fulford was the company who sponsored it first time, and they used to organize every year. Every year they used to organize the PG clinics, and those PG clinics were very useful for the PGs who were to go for the exam, who were to appear for the exam. So with that inspiration, that Fulford has gone, but the legacy is being continued to conduct the PG clinics, and which is very good as far as PG clinics are concerned, because that gives an impetus and the training for the postgraduates. Because nowadays, it's a lot of teaching programs are being inducted into the IIDVL activities, and this being a prime program for the postgraduates. Now, it is a laudable for the Andhra Pradesh IIDVL to conduct this prestigious program regularly. I mean, what I could see that in the last time there was an attendance of 330 have attended. So it's really great to have continued this program of PG clinics. And I'll take this opportunity to invite you all for a DAMOCON 2024 in Hyderabad next month. So I welcome you all. Please do come and take part and actively and enjoy our hospitality and the scientific programs. So please, I request all of you to register if you have not registered, and we will going to put up a hard work, and so that the program becomes successful. So the success will not be there without the participation of our brother states who have been with us for quite a long time. And I'm sure your support and your confidence in us definitely makes the DAMOCON 2024 a great success. So with these few words, I thank all of you for giving me this opportunity of being an external examiner for this PG clinics. Thank you, one and all.
Thank you, sir. Now I request Dr. Soumya, Assistant Professor, GMC, to take over the proceedings.
Warm good afternoon to everyone. Today, it's an esteemed honor to read out the CV of Dr. Gnaneshwara sir. Sir is a professor and HOD, Department of DVL, SVS Medical College, Mehboob Nagar, Telangana. And sir has an immense experience as a postgraduate teacher for last 30 years. And sir has many publications to his credit, that is 80 publications in national international journals. And sir has presented 100 papers at international, national, and state conferences. Sir delivered Dr. Ranade Memorial Oration in 2011 and Rajaram Memorial Oration in 2015. And Sir was awarded Feature Poster Award at World Congress of Dermatology, Vancouver, 2015. And Sir authored a chapter on collagen vascular diseases in IADVL Concise Textbook of Dermatology. And Sir worked as editorial member of IJDVL from 2009 to 2012. Sir is a reviewer for many reputed journals like IJDVL, IDOJ, IJPD, and International Journal of Medical Sciences. And Sir is currently the organizing secretary of DermaCon 2024, which is going to be held at Hyderabad in February. Sir has worked as organizing secretary of Dermazone South in 2018. And Sir has led the team of Telangana State in IDVL 2018. And Sir was IITVL AP State President in 2019. And he was a guest speaker in DermaCon 2013. And he was the scientific committee chairperson of Cuticon AP 2013 and Cuticon Telangana 2015. Yes, sir.
Thank you.
So it gives me an immense pleasure to introduce our internal examiner, Dr. T.S. Mohan Rao, sir. He's a beloved professor and HOD of Department DVL, and Sir has a postgraduate teaching experience of 25 years. And Sir has 20 publications to his credit in international and national journals. And Sir had 15 presentations in national and state conferences. And Sir is a principal investigator of clinical trials conducted in psoriasis and efficacy of Calcipo trial in 2019. And he conducted a clinical trial on apremilast topical usage and double-blind randomized trial which is currently going on for travaconazole and itraconazole, and Humira trial, which is now going on. And Sir worked as secretary IIDVL Visakhapatnam between 2005 and 2006. And Sir led the team of NADVL in May 2020 to 2021. And Sir was a chairperson in many state and national conferences. And Sir is behind the organizing many CMEs which are very educated in last 2020 and 23 in our which are conducted through our Guntur Medical College, that is CME on HIV on 22 December, and leprosy, pediatric dermatosis, and zonal CME on connective tissue disorders, and the most recent CME on STIs. So these are our both internal and distinguished internal and external examiners. And I would like to ask the audience to post the questions in the question box, and the questions will be dealt at the end of the presentations. And over to Dr. Gnaneshwara, sir.
Thank you. Yeah, you can start presentation. The case presentation can be started.
Dr. Jyoti and Dr. Ramya, please start your presentation.
So both the two candidates are presenting the case.
You stop share this one, then another can be shared.
Yes, sir. So both candidates will be answering the questions, sir,
Okay.
and both of them are presenters.
Stop this PPT.
Good afternoon, one and all. We are going to present a case on vesicular bullous disorders.
May I know your name, please? Both of you can introduce your names.
Yes, sir. Good afternoon, sir. I'm Dr. C.H. Sai Jyotirmayi, sir, final year postgraduate.
Good afternoon, sir. I am Dr. Ramya, final year postgraduate.
Okay, right.
A 40-year-old married woman, agricultural worker by occupation.
Just 1 minute. Just while you are presenting,
Yes, sir.
I would like to ask the questions in between also. So that is okay for you?
Yes, sir.
Okay. Yeah, go ahead.
Yes. A 40-year-old married woman, agricultural worker by occupation, came with chief complaints of painful oral areas since 4 months and fluid-filled lesions and raw areas all over body since 1 month. History of presenting illness. Patient developed painful raw areas in the mouth 4 months back that gradually increased in size and number associated with difficulty in swallowing. Lesions did not resolve on their own. Later, she developed multiple clear fluid-filled lesions over face, scalp, trunk, upper limbs, and genitals. Blisters ruptured on their own to form raw areas within 2 to 3 days. Lesions gradually increased in size and number and showed little tendency to heal. There is history of burning sensation on urination. No history of fever, joint pains, and malaise. No history of itching prior to the onset of lesions. No history of diarrhea and painful defecation. No history of hematuria. No history of redness, burning sensation in the eyes. No history of lesions in the trauma-prone areas. There is no history of drug ingestion or topical application prior to onset of lesions. No history of photosensitivity. No history of weight loss. No history of insect bite.
1 minute.
Yes, sir.
No history of drug ingestion and topical application, you said. For the last 4 months, she has been suffering, right?
Yes, sir.
So she must have taken some drugs, no?
Sir, this history is prior to the onset of lesions. That is before 4 months back. There is no history, sir.
Okay, what drugs did you ask specifically?
So we have asked for any antibiotics, sir, penicillin group of antibiotics, or
Okay.
any steroid usage or anything like that, so topical steroids or oral steroids.
Okay. She is not an hypertensive.
No, sir, she is not in high.
Okay. Go ahead.
Yes. There are no aggravating or relieving factors observed as such. Past and treatment history. There are no similar complaints in the past. Patient was treated outside with oral steroids, tablet prednisolone 30 milligrams for 20 days with no significant improvement before presenting to our OPD. Personal history. No history of hypertension, diabetes mellitus, tuberculosis, bronchial asthma, ischemic heart disease, or drug allergies. No history of thyroid abnormality, not a smoker or alcoholic, sleep is disturbed, and appetite is normal. Menstrual history, she had 28-day regular cycles lasting 4 to 5 days with normal bleeding. Her LMP was on 8th of December 2023. Obstetric history, she is married with 2 children, tubectomized 15 years back. Family history is nil significant. On general examination, the patient is conscious and coherent, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Weight is 65 kilograms. Her vitals are pulse rate 88 per minute, respiratory rate 18 per minute, blood pressure 130 by 80 millimeters of mercury. She is afebrile and saturation 99% with room air. Systemic examination, cardiovascular system, S1, S2 heard, respiratory system, bilateral vesicular breath sounds heard, CNS, no focal neurological deficits noted, GIT, soft, non-tender, and no organomegaly noted. On cutaneous examination, multiple bilaterally symmetrical erosions with erythematous base, few with crusting noted over face, scalp, upper limbs, axilla, trunk, inguinal folds associated with foul smell. There are few flaccid vesicles with clear fluid noted over neck and back, measuring approximately 0.5 into 1 centimeter. Few lesions healed with post-inflammatory hyperpigmentation. The approximate body surface area involved is 15%. So these are the clinical images of the patient showing multiple erythematous erosions in the axilla of bilaterally over abdomen. The lesions are noted with crusting. So here we can observe a flaccid blister over buttocks, and here we can notice a few crusting and post-inflammatory hyperpigmentation in the interscapular region over upper back and also in the lower back. Oral cavity, multiple irregular superficial ulcers are noted by over bilateral buccal mucosa, hard palate. Few erosions are also noted over upper and lower lips. Genital mucosa, multiple erythematous erosions noted over labia minora and inner aspect of labia majora. So ocular and nasal mucosa is not involved. Nail changes like paronychia or nycolysis are not observed. Palms and soles are not involved. We did few bedside investigations on which Nikolsky sign marginal is positive and distant is negative. Bulla spread sign is positive. Upon Zanks,
How do you elicit the Nikolsky sign?
so Nikolsky sign can be elicited in the near a blister or erosion or at a distant site. That is, we apply tangential pressure over a bony prominence, and shearing forces will separate the upper layers of epidermis from lower epidermis, extending the erosion, sir.
Okay. What are the conditions where you see the Nikolsky sign positive? Positive Nikolsky sign.
We can see in Pemphigus group of disorders, sir, like Pemphigus vulgaris, Pemphigus foliaceus, and paraneoplastic Pemphigus, sir, variants of both vulgaris and foliaceus. In other genetic disorders like Hailey-Hailey and Darius disease, staphylococcal scarlet skin syndrome and bullous impetigo are few infectious causes where we can see Nikolsky sign positives.
Okay. Bulla spread is also positive. You have written.
Yes, yes. It's positive.
Okay. Okay. How will you elicit the Bulla spread sign?
While applying the lateral pressure, margins of the blister will extend, sir. In Pemphigus
First
group,
encircle it. First you have to encircle the bulla or blister. You have to first encircle it.
yes,
And then you do that.
yes, sir.
Okay, then. Go
Uh,
ahead.
sir, upon applying the pressure, sir, the angulated margins will indicate Pemphigus vulgaris, and in subepidermal blistering disorders, the margins will be like U-shaped margins.
Okay.
Upon Zanksmere, acantholytic cells are noted. Here we can notice an acantholytic cell, which is a rounded
Just hold
keratinocyte.
on. Just hold on. Now, with these clinical features, what is your clinical diagnosis?
Sir, with these features, my provisional diagnosis is Pemphigus vulgaris, sir.
What are the points in favor of Pemphigus vulgaris?
Sir, the age group of the patient is in 4th decade, sir, and she presented with multiple.
The age group that is involved in Pemphigus?
3rd to 4th decade is a common age group, sir.
Common age group, right? Okay.
Then she presented with multiple.
Is there any difference between the male and the female?
Sir, few studies have shown there is a slight female predominance, sir. But in few other studies, it's given as equal predominance.
Equal predominance. Mostly it is equal predominance, right?
Equal predominance.
Okay. What are the other features which supported to the diagnosis?
She had multiple fluid-filled lesions, sir, fluid-filled blisters that burst on their own within a few 2 to 3 days, and those lesions are not healing on their own, sir.
Okay.
And she had oral and genital mucosal involvement and scalp.
Usually the Pemphigus starts in the oral mucosa, the blisters
Yes.
are the erosions. Then
Yes.
you get the lesions typically on the body, right?
Yes,
So in this case also same thing. Early lesions started with the oral mucosa, then she developed lesions on the body.
Bodies.
Okay. Yes.
Yes.
So what are the other? No, the one important aspect you have not told about in the clinical examination is the blisters occur on a normal skin. The The bulla, the blisters
Yes.
usually occur in a normal skin, which you have
Yes.
not mentioned in your examination. Okay, so that is
Yes.
very important point that you should mention, because the evolution, how the vesicle or the blister is occurring, and secondly, whether it is occurring in the normal skin or under the skin, erythematous skin or eczematous skin.
Yes.
That gives a lot of information as to the possible diagnosis. Okay.
Yes.
For example, now what are the other conditions? No, here in Pemphigus, normally what you get is you get the blisters on a normal skin,
Yes.
occasionally on an erythematous skin. So you tell me on what are the other conditions where you get the blisters on an erythematous base?
Bullous pemphigoid, we get lesions over erythematous base.
How do you differentiate?
Arterial clots over arterial.
Yeah, arterial, and there will be severe itching,
Itch.
so which is usually absent in case of
Bullous pemphigus vulgaris.
yeah. The more the symptomatology is towards the pain.
Yes.
Pain is one of the important aspects. Why there is a pain in the case of pemphigus? The blisters patient developing the pemphigus, they develop the pain. Why? Generally, you don't the patients who develop the blisters or like pemphigoid, they don't complain of pain. Mostly the patients who have they develop the raw areas and where the nerve endings are exposed. Like burns. The nerve endings are exposed.
But upper dermis and reticular dermis, we have this free nerve endings.
Yeah, those are exposed. Naturally, the patients do complain of pain, most of them. Okay. So these are the important aspects one should put in when you are presenting a case. The blisters, what is the size of the blister usually? And then a small blister, and it becomes increase in size, which is flaccid in nature. Then it going to go ruptures and forms a big erosion. The erosions are usually not non-healing type of erosions. Okay.
Yes.
So these important points which you should mention in the while in examination.
Okay.
Okay. So what are the other early signs in case of pemphigus? The patient presenting with blisters is one aspect. What are the other early manifestations of pemphigus?
Mucosal involvement.
Say again.
Mucous membrane involvement will be
That is
5
always
months.
there. See, mucous membrane, usually the lesions precede the skin lesions. That is a known fact. What are the other manifestations? Like the paronychia. Paronychia is also one of the early manifestations. Paronychia. Okay. So these are the important points you must to bring out in your examination. Okay. Right. Go ahead.
Upon doing the Zank
Zank smear. No, one more.
Yes.
Zank smear. How will you make a Zank smear?
the roof of the intact
Which one
blister
do you
is
take? You take a developed lesion or an early lesion? Which one do you take for the?
Early lesion will be.
Yeah. Okay. Mm.
the roof of the intact blister is open on one side, and it is the base is gently scraped with a blunt end of a blade, or and it is gently smeared over a slide, and then it is allowed to air dry. After that, it is stained with Ginza stain in 1:10 dilution with distilled water, and it is allowed to fix for 10 to 15 minutes. After that, we'll wash it under running water, and it is observed under microscopes.
Okay. What will you see? What do you expect to see?
We can see the acantholytic cells, sir, which are
What is an acantholytic cell?
sir, it is a rounded keratinocyte with hypertrophic nucleus and increased nuclear cytoplasmic ratio and peripheral rim of condensed basophilic cytoplasm, sir.
Then how does the keratinocyte become the rounded, which you name them as acantholytic cells?
So when it loses its coherence with the adjacent cells, sir, it assumes the least size possible and it becomes rounded.
Okay. What are the conditions where you see the acantholytic cells?
It can be seen in Pemphigus foliaceus, sir, paraneoplastic Pemphigus.
Group of disorders you will see. Okay.
Yes, sir, all Pemphigus group of infectious.
Yes.
Yes, sir. Infectious causes will like herpes group also we will see acantholysis, sir. Secondary acantholysis we will see. For Hailey and Darius disease we will see, sir.
Yeah, you can see, right? Where else you can see?
In secondary acantholysis is also seen in certain tumors like squamous cell carcinoma, basal cell carcinoma also we can see, sir. Keratoacanthoma.
Okay. Okay. Can you clinically differentiate between the Pemphigus vulgaris and Pemphigus foliaceus by looking at the acantholytic cells?
Yes, sir. In foliaceous, the cells will be little bit oval or elongated, sir, and the nucleus is also small when compared to that of vulgaris cell.
Yeah.
And
In
cytoplasm will be more.
Yeah, in foliaceous, there is more triangular in nature. Okay, elliptical or triangular. In nature. Whereas in Pemphigus vulgaris, they are more rounded.
Rounded.
Looking at the even the Zangsmeer, one can possibly make a diagnosis of Pemphigus foliaceus. Okay, right. Next.
So based on the clinical findings and the bedside investigations, we made the following differential diagnosis as Pemphigus vulgaris, bullous pemphigoid, and Pemphigus foliaceus. And our provisional diagnosis was Pemphigus vulgaris.
Okay, go back.
Yes.
Yeah, now you come to the differential diagnosis. Now, what are the diagnoses which you think is possible in these cases? One is you said Pemphigus vulgaris, first possibility is agreed.
Yes,
So what are the other differential diagnoses?
Uh,
Are you justified in talking about bullous pemphigoid? Before that, there should be some more possible other diagnosis, like erythema multiforme. When there is oral mucosa involvement, when there is skin involvement, the blisters are present. So naturally, you have to think of erythema multiforme.
Yes.
Okay.
Yes.
What typical lesions you see in case of erythema multiforme?
Target lesions, typical and atypical targets can be seen in erythema multiforme.
Target lesions, yes. Target lesions will say yes. What are the other things, important things?
Especially acral regions are more involved in the erythema multiforme.
Which one?
Extremities are more commonly.
Acral portions are more involved, yes. And the palms and soles are involved. Palms and soles. Okay.
Yes.
So these are the points you must need to mention. Okay. Then how will you differentiate from the bullous pemphigoid?
Age group of
the elderly people.
Elderly age group, more than 70 years age group, sir. And mostly lesions will be located on lower limbs and lower abdomen, inner aspect of thighs. And the blisters will be tense blisters, sir. Mucous membrane involvement will be less compared, sir. Only 10 to 30% cases might have mucous membrane involvement.
Yes. No, suppose if we take a Zangsmeer, what will you see in Zangsmeer in case of bullous pemphigoid?
Inflammatory
infiltration, sir. Acantholytic cells are not seen.
What cells you will see?
We can see eosinophils and neutrophils, sir.
Yeah, mostly eosinophils and neutrophils, yes. Then your Pemphigus, how to make a diagnosis of Pemphigus, paraneoplastic Pemphigus?
Sir, recalcitrant oral stomatitis is the most striking feature of paraneoplastic pemphigus, sir. Particularly affecting this vermilion border of the lower lip, sir. And the lesions will be very resistant to treatment, and there can be associated occult or an proven malignancy can be associated, sir.
The underlying malignancy is usually. No, one important aspect you have not mentioned about it is the involvement of the palms and soles. In case of paraneoplastic pemphigus. And here you can see the target lesions, particularly in the palms and soles. In the case of paraneoplastic pemphigus, you will see the target lesions. And you suspect when the patient doesn't respond to your usual treatment, that is systemic steroids. You give any amount of steroid, which the patient doesn't respond. So in such situations, yes, you must to suspect the patient might be having a paraneoplastic pemphigus. And to look for investigate for any internal malignancy.
Malignancies.
Yes. Yes. What else? What else other differential diagnosis you can think of? Any bullous drug eruptions? Bullous drug eruptions is also one. What are the drugs which cause bullous drug eruptions?
NSAIDs. NSAIDs.
And penicillin group of antibiotics, sir. NSAIDs.
Your iodome and bromodome, iodines and bromides, they are also known to cause the bullous drug eruptions. Yes.
Yes.
What else the other possible diagnosis?
Epidermolysis bullosa acquisita.
In epidermolysis bullosa acquisita, usually the lesions are on the acral regions, the legs are the common sites, where the tense bullae occur. Bullae will be the tense,
Yes.
and then mostly on the acral portions, like the legs is the common site. Okay.
Yes.
Yes, another diagnosis.
Foliaceous.
Yes, come. Yes, say again.
Pemphigus foliaceous.
Pemphigus foliaceus. How will you diagnose pemphigus foliaceus?
The lesions will be more on the seborrheic areas, sir. Seborrheic distribution of lesions will be present. Mucous membrane involvement is very rare, sir. Mucous membrane involvement, and the lesions will be like intact vesicles cannot be found, sir. They immediately rupture, and we can see only scaling and crusted lesions, sir.
Yes. The Nichols scale will it be positive or negative?
It will be positive, sir.
It will be positive. Okay. Now go ahead. Your presentation.
So upon investigating, routine blood investigations were normal except for elevated ESR, which is 50 millimeter per hour. Virals are non-reactive. RBS is 106 milligram per DL. Urine examination is normal. Chest X-ray and ultrasound abdomen, no abnormality detected, and MAN2 is negative.
No, why do you do the Mantoux test in these cases?
Sir, if you want to give any treatment, immunosuppressives or steroids, for that, we have to rule out any occult tuberculosis. So that's why we have done.
But in any case, you are doing the X-ray test. X-ray test is normal.
Yes.
No, by
It
merely
can be
doing Mantoux test, you are not going to put the patient on. But merely doing a Mantoux test, do you put the patient on anti-tubercle drugs?
No, sir. For reactivation can happen, sir. For that.
Reactivation. Because X-ray test usually you take the X-ray test before you put the patient on any immunosuppressive drug. The Mantoux, I don't think it is necessary. Okay. X-ray test will definitely give whether the patient is tuberculosis is there or not. Okay.
Yes.
Right. Go back. Why do you want to do the viral marker? What viral markers you have done?
Sir, HIV, HBsAg, and HCV we have done, sir.
Okay. Okay.
We have taken a biopsy and sent to histopathology. There.
Before you go to the biopsy,
Yes.
now which one do you take for the biopsy? Which lesion you take? Whether the well-developed lesions or the early lesions?
Early lesions are within 24 hours should be taken, sir, for a biopsy.
Okay. What is the earliest histopathological feature?
Eosinophilic spongiosis is the earliest feature, sir.
Yes, okay. Yes.
See,
Yeah,
here
tell me.
Yes. Here the section studied showed suprabasal acantholysis with intact basal layer, intraepidermal neutrophilic infiltrates, and sparse lymphomononuclear infiltrates around the vessels. Features
How do you classify? One minute. How do you classify acantholysis?
It is classified as primary acantholysis and secondary acantholysis, sir. Primary acantholysis is because of disruption of the desmosome, sir, either due to hereditary defects or acquired. And secondary acantholysis is due to damage to the keratinocyte, secondarily causing disruption of these desmosomes, sir.
Okay. Any other classification you have? Acantholysis?
Biochemical acantholysis also present.
Okay, right. Okay. And tell me.
So this is the image showing histopathology image in low power magnification, and this is in 40x showing suprabasal split with intact basal layer.
Mm-hmm. No, go back, go back.
Yes.
Yeah, you tell me. Yes, now you tell me.
So this is the intact basal layer, sir, and here we can notice the suprabasal split, sir.
Suprabasal cleft, yes.
Cleft is present with some infiltrates around vessels, sir, in the dermis.
Yeah.
These are the
You can see
infiltrates.
the row of tombstones. That row of tombstones.
Here we can notice, sir, in
Yeah,
this. Yeah.
Actually, you should take a square image, not the round image. A round microscopic image. You should always take the square image, square photo. Okay.
We have sent a sample
So
to
what will
direct.
be for the immunofluorescence, which part of the bulla you will take?
So we have to take perilesional skin for biopsy, sir. More than 1 centimeter from the vicinity of the lesion, sir. Normal looking skin. From normal looking skin, we will send for DIS.
Okay.
And DIF demonstrated a fishnet pattern with IgG and C3 deposits, sir. Here we can observe this fishnet pattern, sir.
Okay. Now, 1 minute before you summarize. No, what are the media for the storing the biopsy for immunofluorescence?
The Michael's media is used for the transport of direct immunofluorescence specimens. We
Okay,
can
how
also transport
how
in
long you can keep in Mitchell's medium?
2 weeks we can store up
Not
to
2
2
weeks.
weeks.
6 months, up to 6 months you can keep it in Mitchell's medium. So that is a medium which preserves it.
Yes.
Okay.
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 So to summarize our case, all the positive findings, she is a 40-year-old female with multiple raw painful erosions in the mouth and multiple symmetrically distributed fluid flaccid blisters and erosions all over body with little tendency to heal, and these lesions developed on a normal skin. Nikolsky and Bulla spread sign are positive. On Zang smear, they showed acantholytic cells. Biopsy showed suprabasal split and direct immunofluorescence showed fishnet pattern. Hence, we came to a diagnosis of Pemphigus vulgaris.
Okay. No, how will you manage this case?
So we classified
Yeah, tell me.
So depending upon the involvement, we have classified the patient according to the PDAI score, Pemphigus disease area index, into moderately severe involvement, sir. And then have started the patient after investigating all the routines. We have started the patient on dexamethasone cyclophosphamide pulse therapy, sir. Along with that, we have kept the patient on oral antifungals and systemic antibiotics, sir. Also, we have given topical therapy with antibiotics in the morning, fusidic acid, and at night we have given the patient clobetasol propionate 0.05% ointment over the erosion, sir. And we have also included this chlorhexidine mouthwashes and triamcinolone acetonide oral paste for these oral lesions, sir. We have given this mucopain 20% benzocaine gel 20 minutes before food to elevate the pain because of these oral lesions, sir.
Go back. Go back. Yeah, you started the pulse therapy straight away, isn't it?
Yes. Yes, sir.
So what is the usual protocol? Of course, there is little controversy as to some people do start the pulse therapy, DCP, and some people start this treat the high doses of systemic steroids, then bring the disease under control, and then go for the pulse therapy. I mean, that's what have been doing it. So initially, what one should do is to bring the disease under control, for which you need to use systemic steroids. Usually, about how much doses you give? You want to give an injectable steroid?
Sir, in mild cases, we can give 1 milligram per kg body weight. In moderate to severe cases, we can give 1.5 milligram to kg
Okay.
per kg body weight, and maximum 2 milligrams also can.
Okay. But usually you should start the high dose of steroids, and simultaneously you should put the patient on the prophylactic antibiotic when you are giving such high dose of steroids.
Yes.
Prophylactically, you should start an antibiotic.
Yes.
Suppose you want to start an antibiotic, which antibiotic do you want to start?
Yes, cephalosporin group of antibiotics.
Cephalosporin. Cephalosporins are known to give rise to or aggravate the pemphigus.
So we will like to give clindamycin or linezolid.
Yeah, those are the better drugs, because those are the drugs that are not known to give rise to pemphigus or aggravate the pemphigus lesion. Okay. What else you want to give? Dexamethasone. Along with the dexamethasone, what else you want to give when you are putting the patient on a prolonged steroid?
Anti
Anti?
to prevent this peptic ulcer disease, we can add Pantop injection.
Okay. Now that leads to the question of what are the side effects of steroids?
Yes. So there can be systemic side effects and cutaneous side effects. In systemic side effects, we can have this multiple system involvement, sir, like metabolic side effects are like hyperglycemia we can have, sir. Electrolyte imbalances like sodium and water retention and hypokalemia, sir. Then bone side effects like osteoporosis and osteonecrosis can be seen, sir. And GIT side effects like peptic ulcer disease and gastroesophageal reflux can be seen. In CNS, like seizures, cancer, and psychosis can be seen. And
What is the effect on the metabolism, protein metabolism, carbohydrate metabolism?
Sir, it causes lipodystrophy and lipolysis, sir. Protein catabolism it will cause, sir. It will cause gluconeogenesis and glycogen formation. It increases the insulin resistance, sir. Hyperglycemia can be produced.
Yes. Now, along with this, what else you give? Generally, you put the patient on potassium supplements.
Yes, sir.
Potassium supplements. So, what are the potassium supplements that are available, and how much you give?
Pot flour syrup, sir. 15 ml will contain this 20 milli equivalents of potassium, sir. We can add this twice to thrice daily, sir. 10 ml of syrup can be added twice or to thrice daily.
Okay. Suppose you want to give dietary supplement, what will you give? Dietary supplement for the potassium.
Coconut water can be given.
Coconut contains a high lot of potassium, high content of potassium. Usually, one banana is enough to
yes, banana.
supplement to the potassium.
Okay.
And similarly, ask the patient to take the calcium also, because you need to use supplement the calcium, because there is likely to be hypocalcemia, right? Okay. Suppose the patient is not responding. When you start the steroid, the patient is not responding. So what are your other options?
We can go for immunomodulatory agents, sir. Like cyclophosphamide, azathioprine.
Do you call them immunomodulatory or immunosuppressive?
Immunosuppressive agents.
Immunosuppressive, not immunomodulators. So what are the immunosuppressives of your choice?
Azathioprine and mycophenolate mofetil, sir.
Okay, why the azathioprine is preferred?
Sir, in young patients and who have not completed their family, azathioprine is the preferred drug, sir. Because cyclophosphamide can cause this gonadal failure in both males and females.
What is the prerequisite for the azathioprine to start.
We have to check this TPMT levels, sir. Thiopurine methyl transferase enzyme levels, sir.
How much
Before
it costs, you know that? How much is this test cost? It is not a routine investigation. I mean, it is not a cheap investigation.
yes.
How much it costs, you know that? No, it costs 5,000 rupees. It is rarely available and it costs 5,000 rupees. So usually it is not possible to do a TMPT. But however, a legal point of view, it is always, when you prescribe azathioprine, you always write on your prescription that TMPT test. If it doesn't get it done, it is his headache, right? So, but it is your responsibility, because tomorrow you can be dragged to the court for the simple reason that you are not advised, and without that you started the drug. So whenever you want to prescribe azathioprine, you must always advise the patient to get it done. Okay, you are safe. If he doesn't get it done, it is his prerogative, right? Okay. So how much dose you give?
Azathioprine, 1.5 to 2.5 milligram per kg body weight can be given, sir. Up to 3 can also be 3 milligram
Available
per
in
kg.
what preparations? What strength it is available? Azathioprine.
25 milligrams and 50 milligram tablets are available.
50 and 100 milligrams are usually the available
Milligrams,
tablets, right?
sir.
Okay. When you combine both the azathioprine as well as dexamethasone, the immunosuppressive effect will be much more than with a single drug. Okay, so with this combination, what do you expect in the patient?
Myelosuppression could be a side effect of azathioprine.
Yes, myelosuppression and infection. Infections is a common problem. The patients with such big areas, the local infection as well as systemic infection. The patient can land up in a systemic infection. Particularly septicemia, they are more likely the patient can go into septicemia when you are combining both these drugs. Okay, so it's always better if you are able to control the disease activity with steroid alone. Okay, but however, the steroids are not going to be effective, not going to be used for longer periods. For that reason, we always try to combine with an azathioprine in a dose that gives an adequate response. Okay, now we have, now when do you expect the patient to respond with these with the treatment?
So with the azathioprine, up to clinical effects will be seen after 3 months. 2 to 3 months, we can expect the clinical effects.
2 to 3 months? No,
Sir?
now you started the treatment. Both these drugs are started. How much time do you wait?
So 2 to 3 weeks it will start, sir.
2 weeks. Usually, the 2 weeks are sufficient for the patient to respond. If he is not responding, then there is something wrong with the patient. Okay, so you need to, within 2 weeks, you expect the patient to respond. Okay. Then when you are combining both the drugs, what are other problems patient can develop? What are the long-term side effects of immunosuppressives?
Certain malignancies will be
Yes,
there.
malignancies can crop up, yes.
Yes. With azathioprine, non-melanoma skin cancers risk will be there, sir, and genitourinary risk will be there, sir. Genitourinary malignancy risk.
Yes. Now you are written about oral cyclophosphamide.
Yes.
Now compare both the drugs, azathioprine and cyclophosphamide, which is more potent immunosuppressive.
Cyclophosphamide is more potent.
Yeah, cyclophosphamide is more potent than the azathioprine. So when you want to get a good immunosuppression, you should always start in the cyclophosphamide. Once you get stabilized, then you can shift to the azathioprine. Usually that is being followed. Okay.
Yes.
So how will you give an antibiotic? Ideally, only when you want to start the antibiotic, what are the tests you want to do?
Culture sensitivity of this discharge from the erosions we
That's
have
one.
to
Yes. And you need to do a blood culture also.
blood culture sensitivity.
Blood culture also you should do. Okay. And before, when the patient is on these, particularly the steroids and as well as the immunosuppressives, you do in the culture and give an appropriate antibiotic in an adequate dose. Then only the patient will be, his infection will be under control if it is there. Otherwise, the patient is likely to go into septicemia. So, what are the early signs of septicemia?
Sir, increased WBC counts in CBC, sir.
Clinically, I'm asking clinical. The patient is on immunosuppressive as well as systemic steroids, right? Both are immunosuppressives. Now, how do you know the patient is going into septicemia? What are the early signs of septicemia?
Fever, non-healing of these wound.
Listen to me. The patient doesn't develop fever when he's on steroids. So fever is not a sign that you can take into consideration in a patient who is already on systemic steroids. Tachycardia is one of the important signs that you should look for when you want to put the patient to know about how the patient is responding to your treatment or whether the patient is going to septicemia. So tachycardia, look for the tachycardia. The pulse rate, regular monitoring of the pulse rate will give an indication that probably this patient is going to septicemia. Because none of the signs, other signs like the what you call the temperature, you will not develop temperature. Okay. So these early signs are important so that the patient's life can be saved. Okay. Yes, then suppose, for example, now the other option is you have the DCP. DCP, you have 4 phases, all those things are there. So how do you manage? Suppose if you want to give the DCP.
It is given in 4 phases, sir, DCP. In the first phase,
You know who started the pulse therapy?
Patricia has started.
Patricia was the first person who started the
DCP.
pulse therapy. In which case you do know?
Writer's disease. Writer's disease.
Yeah, Reiter's disease, right? Yes. Not in Pemphigus. It was started in Reiter's, but it was later on extrapolated to the Pemphigus. Sorry, Pemphigus group of disorders. Right? Okay. Then when you are giving cyclophosphamide, what else you want to give? When you are using cyclophosphamide along with pulse therapy, what else do you want to give?
Mesna, in cases of bladder toxicity, we have to give Mesna, sir. Mercaptoethane, sodium mercaptoethane sulfonate.
What are the uses of Mesna?
Sir, it binds with this acrolein in this bladder and prevents and the acrolein is eliminated, sir, because this acrolein causes hemorrhagic cystitis, sir.
Yeah, hematuria. That is one of the common manifestations when the patient is not given the Mesna. But however, in our experience, when the patient is asked to take a lot of fluids, this problem you don't encounter generally. Mesna is, I don't have the experience of using Mesna, but generally the patient is advised to take a lot of fluids, then this symptom is not encountered.
Yes.
Okay. Next. Yes. Now you are written about prophylactic fluconazole.
Yes.
No, is it necessary? Prophylactic fluconazole.
Sir.
Unless there is a definite oral thrush, there is no requirement. Okay, you can, if there is an evidence of thrush, that is candidiasis, then you can give oral or topical antifungals. Okay. Now, for example, what are the other options for in the case of recalcitrant pemphigus, where the patient is not responding to your systemic therapy, systemic steroids, and systemic immunosuppressives. What are the other options?
Rituximab can be given, sir.
So what is rituximab? How does it act?
It is a chimeric anti-CD20 monoclonal antibody, sir.
Yes.
It blocks the CD20 receptors over from pre-B cells to B cells. It will block the CD20 receptors, sir,
Right.
thereby inhibiting the antibody production, sir.
Yes.
It also downregulates these E-selectin, P-selectin, and this adhesion molecules, sir, thereby preventing this chemotaxis and release of these inflammatory substances.
Okay. No. Now, is it approved by the US FDA?
Yes, sir, it is approved, sir.
Yeah,
FDA.
it is approved in by US FDA in 2018 itself.
Yes.
It was approved and is being used nowadays. It is now people take it as the first drug of choice.
Yes, sir.
Rituximab. Provided the patient affordable,
Affordable.
then you can definitely give the rituximab. Now there are two protocols. What are the two protocols?
One is a lymphoma protocol, sir, and the one is rheumatoid arthritis protocol, sir.
Which one do
Lymphoma,
you use? Which one?
for dermatological purposes, rheumatoid arthritis protocol is being followed, sir.
That is 375 milligrams per square meter. Right?
1 gram, 1 gram, sir. 1 gram, 2 weeks apart, sir.
1 gram
Again,
to
2 weeks apart.
2 bits.
After 12 months, another 500 milligrams will be given, sir. Thereafter, every 6
this
months.
you give every month. This you give every month. How do you manage the dosage?
No, sir, we will give it once in 6 months thereafter, sir. After these 2 doses, yearly. After these 2 doses, 2 weeks apart, sir, we will give it again after 12 months. And from there, we'll give it every 6 months, sir.
Every 6 months. Okay.
Yes.
So, how is the prognosis with this?
Sir, a median remission time is for each dose, it will be around 14 to 15 months. The patient will be in remission, sir. It will take approximately 5 months to go into complete remission with this, sir, from the first dose.
Okay. Now, how much time does the your DCP takes for the remission?
3 months.
3 months.
I mean,
No,
it will
DCP
start
time
by
itself
2
is
to 3 weeks.
long.
It will start, sir.
Hmm?
From 2 to 3 weeks, the lesions will start. The patient will start in remission or consolidation phase will begin after 2 weeks, sir.
Okay. For example, if the patient is diabetic, you have to give DCP. How to manage?
We can give in diabetics also, but 8 units of insulin should be added to the infusion, sir, in diabetics.
Okay. 1 unit to bring down the sugar by how much? No idea. Now, 1 unit of insulin brings down 50 milligrams of blood sugar. So you have to be very careful when you are adding insulin. But generally, this stabilized pattern or protocol is to add 8 units of insulin.
Yes.
Sir, if the patient is diabetic. Okay. Yes, what else can we? No, we discussed about the complications also, long-term complications, short-term complications. I think any other point we are not covered. I think we have covered everything. Now, one point, how to assess the severity of the disease? For example, we want to prove it by doing a test.
By
Indirect
immunofluorescence,
immunofluorescence or ELISA, we can.
Yeah,
definitely-
indirect immunofluorescence. Indirect immunofluorescence will give an assessment of the severity of the pemphigus. So that's all about the case discussion. Dr. Mohan Rao, I think I have finished the examination. And you want to ask any questions, you are welcome.
Voice
I'm not able to hear. Your voice is no. You have to unmute.
Jyoti,
Yes, sir.
tell me the histological difference between Haley and Pemphigus vulgaris. Histological, how it differs from benign familial Pemphigus.
Sir, in Haley disease, there will be dilapidated brick wall appearance, sir, and in few cases, dyskeratotic cells also can be seen, sir.
What else? What about the villi and clefts?
Villi and
What about
clefts,
diskeratotic cells?
dyskeratotic cells will be present, and villi and clefts are also seen in Haley disease, sir.
What is the size of acantholytic cell? How do you account for this round nature of acantholytic cell? The cell is polyhedral. How it becomes round?
Size is approximately 20 micrometers, sir. When it loses its coherence from adjacent keratinocytes, sir, it assumes the smallest possible shape and hence it becomes round, sir.
Okay. Any latest advances in the management of vulgaris? Any biological latest advances?
Yes, CD20 monoclonal antibodies are present, sir. Veltuzumab, ocrelizumab, sir. Now, Bruton tyrosine kinase inhibitors also present, sir. Rilzabrutinib and tirabrutinib, sir.
Tell me the rare side effects of this rituximab.
Infliximab, yeah.
The rare side effects.
Progressive multifocal leukoencephalopathy is one of the rare side effects, sir.
Any ectopics you observe? Ectopics? Atrial fibrillation.
Atrial fibrillations.
What is that symptom called as?
P-wave
Huh?
P-wave dispersion, sir.
Yes.
Arrhythmias is one of the common.
Rituximab and CLL, any side effect you can observe? In malignancies, when you go in rituximab in malignancy, do you see any lysis syndrome? What is that?
Tumor lysis syndrome can be observed.
Yes. Okay. Sir, Ganeswar sir.
Yeah.
Arrogant sir.
IVIG have you used? Have you experienced any IVIG? Immunoglobulin, IV immunoglobulins.
For this Pemphigus cases, we are not using IVIG here.
But they can be used. These can also be used.
Yes.
But the results have not been very encouraging. Some studies have shown that it gives good result. Then you have the plasmapheresis also. Plasmapheresis, and you have other modes of treatment like the withdrawing the blood, then exposing to the photochemotherapy. So those things are very advanced treatments. Only few centers can afford it. But mostly the drug of choice is steroids, immunosuppressives, and now latest is the rituximab. So that is the order of the drugs that can be used in case of Pemphigus. Any systemic associations with the Pemphigus?
Other autoimmune diseases can be associated, sir, like Hashimoto's thyroiditis, type 1 diabetes, myasthenia gravis, and thymomas.
Yes. Mohan Garu, I think you can ask questions or we can go ahead.
Saujanya, what to Saujanya? Saujanya.
Sir, we can take the questions from the chat. Soumya can take the questions from the chat.
1 minute.
I think Dr. Akshay can help. Any questions in the chat?
Hello, ma'am. It is in a chat box.
Okay.
You just read it out.
So, what are the side effects of TCP pulse therapy? Typing. So, what is the composition of Michael's medium?
55 grams of ammonium sulfate in 100 ml of buffered solution, which contains this potassium or sodium citrate, and N-ethyl malamide, and magnesium sulfate.
How do you treat a case of recalcitrant oral pemphigus when all therapies fail?
Like intralesional steroids is one option for recalcitrant oral and scalp lesions of pemphigus, where triamcinolone estonide is given intralesionally of 10 to 20 milligram per ml concentration.
You can give this CO2 laser also at a dose of 3 to 5.5 watts continuous mode. We can give this CO2 laser for especially for recalcitrant vigilance. And we can give this intralesional, Ritix, intralesional thalidomide or intralesional leflunomide can be tried in recalcitrant cases.
But they are very resistant. Whatever you do, they still oral lesions persist. So that is really a problem for the treating physician.
Apart from rituximab, are there any other biologicals that can be used in pemphigus vulgaris?
Already checked.
I think so.
Is another alternative drug.
Veltuzumab and ocrelizumab.
Then
What are the newer advances in investigations of pemphigus vulgaris?
You can do immunofluorescence in the hair. Here, you can pick up the hair and do the immunofluorescence that can show the features of pemphigus immunofluorescence. There was recently one article in IJDVL on the early diagnosis of pemphigus by taking the hair follicle for the immunofluorescence. There's a very good article in IJDVL. I don't remember the name, but it is there, where you can take a hair follicle and do this. That is early feature of the for early diagnosis of pemphigus.
Now we have these biochips also, sir.
Which one?
Biochip.
Biochips. Okay.
Biochip containing all the 6 things. You can just put 1 drop and you will get pemphigus, pemphigoid, ABA. And so 1 chip contain all the 6, costs only 2,500 to 4,000 different centers. So that's the latest advances.
Is it costly?
4,000 rupees, sir.
5,000 rupees. Okay.
So that's all. So there are no more questions in the chat box, sir. Sitaram sir, you would like to ask any more questions?
Not questions at all, but I mean, I appreciate Professor Ganeshwara sir to bring out a lot of clinical discussion in the cases. I mean, he even said that the square histopathology images are required. That is true. In the publication, whenever we are sending, never send a round image. We will never accept it. Always we need only a square images. Cut down the borders and try to make it. And he discussed very detail all the science and how do we elicit and how do you present, what do you see. So thank you very much for all that, excellent information which you have given to the postgraduates. And the Mitchell's medium, he has asked how long we can keep. Other media, anybody, so you can tell anything else. If it's not there with you, how can you send that?
And in a normal saline also we can send, sir.
That's true. In the normal saline also you can send, but even it can reach center in 6 to 8 hours time if it is nearby. Even if nothing is there, it's suppose if the center is in Vijayawada, you can send it, just freeze it and then send it. If it is less than 2 to 3 hours. Any other medium? Normal saline, freeze, which else? Any other? Honey. Isn't it? So you can send it even in the honey. So while discussing DCP therapy, Sir has brought out a very important point that you should never start DCP straight away if there is any secondary infection. We have to control the secondary infection first, stabilize, and then start the DCP therapy. So infection is there and septicemia is inevitable. So when you are giving such higher doses, so stabilize the patient, rule out the infection, control the infection with antibiotics. During that time, you can treat with the conventional steroid dosage. Once the infection is controlled, yes, then you can go for the DCP pulse. As you said that you can have the different phases of treatment. Rituximab, one statement I heard that we repeat every 6 months. I don't think it's necessary. It's not like that. You should not give rituximab in less than 6 months period. That is the time which we should remember. Don't repeat the dose in less than 6 months period because the lymphocytes will not regain. So at least you give a gap of 6 months. And if necessary, you can repeat after 6 months. Not that you will give once in 6 months later on. So that is another point which I just make to. Biochip, I already said that it is available. And in some centers, they do it for even 2,500. And some centers, they have 4,000 rupees. 6 diagnoses will come. Any things, I mean, Pemphigus vulgaris, foliaceous, pemphigoid, and what is it, EBA. So 6 things will be there in that chip now. So those are available in the commercial project. So I think that's, and I personally sincerely thank Professor Mohan Rao and Professor Ganesh Rao sir for initiating and taking the discussion so well. And I think it's definitely useful to all our postgraduates. So thank you very much.
Thank you, sir.
So just a small question, sir.
Mohan Rao garu and Dr. Kavita and everyone, and even the PGs who have attended this program. I thank them all for having a patience to listen to the questions and answers. And thank you all.
సార్ మీకే థ్యాంక్స్ చెప్పాలి సార్, అడిగినట్టే మీరు యాక్సెప్ట్ చేసినందుకు.
You're so busy with the conference, still you accepted, sir. We are all greatly indebted to you. Thank you.
Thank you. Thank you so much. Thank you, Dr. Kavita.
Thank you, sir.
Thank you very much, sir.
President, for her great enthusiasm, and Dr. Sitaram sir, who is ever encouraging. And I thank the viewers who will give us the more number of participation, will give more energy to do further endeavors. And I thank particularly Gloderma for their technical support. Thank you, one and all.
Thank you.
Thank you, ma'am. Thank you.
Thank you.